Submitted. All right. Welcome, everyone. I'm Allison Pishko, and we are going to get started on our hematology deep dive today. We will be doing the treatment of bleeding in HHT, iron, blood and systemic therapies, and iron replacement therapy. Just some introduction slides before we get started. This is put on by Blood SA Foundation, driving excellence in hematology. And a huge thank you to the deep dive management team for putting this together, including the deep dive team leader, Professor Estelle Verberg. This is Taryn Solomon, who's the administration and communication leads, Mrs. Brooks in administration, and Dr. Melinda King, who's the medical officer and educational platform coordinator. Some housekeeping notes. This session will be recorded. All of the sessions for Blood SA are recorded and can be found on our website, bloodsa.org.za, under Resources Deep Dive. We do hope that this will be a very interactive session. During the session, just please mute yourself during the presentation, but please feel free to add any questions as we go along into the chat box. We will respond to any questions that are put into the chat box at the end of the presentation. We'll also give you the chance at the end of the presentation to unmute yourself and ask questions live. For CPD points will be submitted to the HPCSA for each registered South African attendee. Please ensure you are attending with your own registered Zoom link and not in a group. You have to attend for at least 1 hour for the CPD points. Your HPCSA number is entered correctly when you sign up for Deep Dive. For any queries or if you would like to get a certificate for another council or country, you can email the admin team at the email address there. Please do join the mailing list. You can join the mailing list via our website or using the QR code displayed there. Under resources, subscribe to Deep Dive. For any feedback is welcome on behalf of Blood SA and the speakers. We value your honest feedback, and you can complete the anonymous feedback survey at the end of the Zoom meeting. Some upcoming events to highlight before we get to the presentation is the 6th National Cell and Gene Therapy Conference in conjunction with Heritable Human Genome Editing Conference. That's coming up in October 27th through 29th. There is also Beyond Boundaries from Progress to Access being held at the beginning of October, October 2nd through 4th, and registration abstracts information is below. And next week, it's going to be another bleeding disorder topic from evidence to practice, APCC, and hemophilia care. So to get to today's talk, we are going to be reviewing the treatment of bleeding in HHT, iron, blood, and systemic therapies and iron replacement. We're honored to have Dr. Hanny Al-Samkari. We'll do some Q&A at the end. As we mentioned, feel free to use the chat or to ask your question at the end, and then we'll do a closing statement. So about our speaker today, Dr. Al-Samkari is the Peggy S. Blitz Endowed Chair in Hematology Oncology at the Massachusetts General Hospital and Associate Professor of Medicine at Harvard Medical School. He is a classical hematologist and NIH-funded clinical investigator. He also serves as the co-director of the MGH Hereditary Hemorrhagic Telangiectasia Center of Excellence. His clinical and research interests are in hemostasis, thrombosis, and hemolysis, with focuses in HHT, which we'll speak on today, thrombocytopenias, and hemolytic anemia. Dr. Al-Samkari is an internationally recognized expert in the clinical development of novel therapeutics for these disorders and serves as the lead principal investigator for multiple ongoing clinical trials. He is a current associate editor of the American Journal of Hematology, a leading international hematology journal, and the Journal of Thrombosis and Hemostasis, which is the flagship journal of the International Society on Thrombosis and Hemostasis. His original research has been featured in the New England Journal of Medicine, the Lancet, Annals of Internal Medicine, and Blood, among other top peer-reviewed journals in hematology and medicine. And without further ado, we'll have him take it away with his presentation today.
Wonderful. Thank you so much, Dr. Pishko, for that very kind introduction. And thank you to Blood SA for the very kind invitation. It's an honor to be here and to speak with you all today on HHT. So just want to make sure that everybody can see my slides. Okay, I think we're good. All right. So here are my disclosures. So let's start by talking about the spectrum of inherited bleeding disorders. I like to think about inherited bleeding disorders like this. And I hope that after today's talk, you will perhaps join me in thinking about them this way, because I think in many circumstances, right, HHT, which is our prototypical vascular structural problem, inherited bleeding disorder, often gets forgotten about. This is, I think, in many ways, a somewhat forgotten disease or perhaps a neglected disease in the hemostasis space. And we're really changing that. And that is really changing worldwide, actually. It has been changing the last few years and will be continuing to change. But right on one end of the spectrum, we have our prototypical coagulation factor problem, hemophilia, 1 in 10,000 people, 1 in 5,000 men. On the other end, we have HHT, 1 in 5,000 people, so about twice as common as hemophilia. And then in the middle, we have von Willebrand disease, which of course is both, right, as a von Willebrand factor, a critical coagulation factor, and also a very critical natural anti-angiogenic protein, which is why so many of these patients can develop abnormal blood vessels that can bleed and cause issues. The prevalence of vascular anomalies in VWD is probably underestimated. We do know if you look at nail fold capillaroscopy in 100 patients with VWD, including all of the various different subtypes of VWD, not just type 2A, you have abnormal nail fold capillaries in about 80% of them. So we're here to talk about HHT today, and I'll just give everybody a brief introduction to HHT, recognizing that unlike those of us who direct HHT centers, you might not think about it all day, every day. So just as a reminder of some of the clinical manifestations and how we diagnose. So HHT, as we know, multisystem inherited bleeding disorder with numerous morbid and potentially fatal manifestations, right? So we have the sine qua non of the disease, which is the recurrent epistaxis that affects over 95% of patients, but also 75% of patients have gastrointestinal telangiectasias, and about half of those patients have clinically significant chronic gastrointestinal bleeding, or about 1/3 of all patients with HHT. Very common for patients with HHT to develop iron deficiency anemia. This occurs in most patients with the disease, and it's often iron infusion dependent. It can, in the most severe patients, about 5% of the most severe patients, be red cell transfusion dependent. Visceral arteriovenous malformations occur primarily in lung, liver, and brain, but can also occur in other places like spine. These lead to a whole host of both bleeding and non-bleeding complications, including high output heart failure, liver disease, pulmonary hypertension, brain hemorrhage, pulmonary hemorrhage, epilepsy. Despite this rather substantial burden of bleeding and non-bleeding manifestations, and remember that most patients with HHT have AVMs in at least one solid organ, in addition to their telangiectasias and AVMs in their nose and intestines. Despite this, patients rank bleeding as the most important clinical manifestation, and by a wide margin, right? Because bleeding from your face constantly all the time is a problem, is very bad. There are no approved therapies to date. So as an autosomal dominant disease, when you find one patient, you have half of the family waiting behind them, potentially waiting to be diagnosed if they haven't already been diagnosed. This is the most clinically significant and morbid inherited bleeding disorder of women, substantially more morbid than von Willebrand disease. And of course, women are only carriers for hemophilia. And while occasionally a female carrier of hemophilia can have significant bleeding symptoms, that is unusual, right? So HHT, just given its prevalence, its inheritance, and its morbid manifestations, is the most clinically significant and morbid inherited bleeding disorder of women, which oftentimes people don't think about unless you really think about it. Then you realize, oh yeah, that makes a lot of sense. The bleeding manifestations and the visceral disease manifestations actually also appear to be more severe in women. They certainly can be severe in men, but very commonly more severe in women. Patients with HHT have reduced overall survival compared with healthy controls, and HHT affects about 1.4 to 1.6 million people worldwide. So let's talk about pathophysiology very briefly, which is instructive as we think about therapeutics. So we have the endothelial surface here, okay, the cell membrane. We have our ALK1 BMPR2 endocrine signaling complex, which is the brakes on angiogenesis, okay? This works in concert with other signaling pathways that are more pro-angiogenic, like VEGFR2 and apelin, a G protein coupled receptor that's very pro-angiogenic. So our brakes on angiogenesis are vascular quiescence pathway, BMPR2 ALK1 endoglin, this complex that includes multiple different receptors here. Um, Normally, under normal circumstances, is important in getting endothelial proliferation to stop, in getting vessels to mature, and getting the sprouting of blood vessels to stop when it should stop, and have normal maturation of blood vessels and angiogenic balance. This is in balance with our pro-angiogenic pathways. In HHT, you have haploinsufficiency of the brake pedal. You have 50% less braking than you should, and therefore the balance between brake and gas is disrupted. From the time someone is in utero, right? From the time they're a fetus, you have a signal for excess blood vessel growth, for loss of vascular quiescence. This leads to excessive endothelial proliferation, ultimately poor vessel maturation, and the formation of these anomalous vascular structures, arteriovenous malformations, and telangiectasias. Now, in HHT, the most common mutations are in endoglin, which is a critical co-receptor for ALK1, or ALK1 itself, which complexes with BMPR2. So this is called the ALK1 signaling pathway for short. All right. You can also have mutations in BMP910, which is very unusual, but can happen, the ligand, or mutations in SMAD4, which is downstream. We clinically will use certain medications off-label, like bevacizumab or pazopanib, to inhibit VEGFR2 signaling, either by blocking VEGFR2 itself with pazopanib or inhibiting the ligand for VEGFR2, which is VEGF-A, with bevacizumab. There are also other treatment modalities that I'll mention later in the talk. There is also, actually, I'll mention this now, right? Some of the newer medications like AKT inhibitors, which I'll mention briefly at the end of the talk, that are being developed specifically for HHT, not as off-label medications, but as medications developed specifically for the disease. This includes drugs like engacertib, ATV-1601, and TER-4480. All right, sorry, I think I accidentally put that in there twice. All right, so how to best care for iron deficiency anemia in patients with HHT and chronic bleeding. This is the first this is one of the major pillars of HHT management, one of the three major pillars. And like a stool with three legs, without one of the pillars, then the stool will collapse, right? So we have to make sure we're adequately managing anemia and iron deficiency. That's one pillar. We need to make sure we're adequately managing bleeding with proper therapy. That's another pillar. We have to make sure we're adequately preventing AVM complications and managing visceral AVMs. That's the third pillar. So it is almost impossible to give a patient with HHT too much iron. That is, I think, a very important take home, okay? It is very, very easy to give them an inadequate amount of iron. It's very, very easy to give them the wrong kind of iron, and I'll get to that in a moment. But in general, these patients, over 90% of them, despite their bleeding burden, despite chronic epistaxis and potentially chronic gastrointestinal bleeding and potentially heavy menstrual bleeding, which appears to impact between 40 and 70% of women with HHT, and that's something that's only now being more studied. 90% of these patients, more than 90% of these patients, can achieve a normal hemoglobin if adequately and aggressively treated with intravenous iron, right? So I have here modest goals for people's iron, which is a ferritin greater than 50 and transferrin saturation greater than 20%, right? These are chronically bleeding patients. You really, when their ferritin is 64 and sitting in your clinic today, it's going to be lower in a couple of weeks, unlike a typical patient, right? So it's really important to be aggressive and proactive about treating iron deficiency in these patients. Most patients, oral iron is inadequate. Right? Oral iron can sometimes cause a patient to tread water, so to speak, where their hemoglobin is normal, but their ferritin is in the 20s or the teens. Their transferrin saturation is 12%. That's not adequate. That's chronic iron deficiency. Patients with HHT with chronic iron deficiency not only deal with all of the, morbidities of chronic iron deficiency, which the patient may themselves not be aware of because they're so used to it, but they have an increased risk for thromboembolism. And iron deficiency, we know that iron deficiency is one of the major modifiable drivers of thromboembolic risk in HHT. patients who are iron deficient have higher factor VIII levels, and that drives increased thromboembolic risk. And this isn't a disease of increased thromboembolic risk at baseline. All right, so AVMs, telangiectasias, what are these things? These are abnormal vascular structures in which the normal physiologic capillary bed is bypassed. They're high flow vascular malformations. So high flow vascular malformations are certainly when they are disrupted and when they're fragile and when they break, right, can cause rather substantial bleeding. This is why patients with HHT can get really gushing bleeding from their nose. All right. A telangiectasia is just a small AVM. It's an AVM that's up to a few millimeters in size. When it's more than a few millimeters in size, we will call it an AVM. When it's smaller, we call it a telangiectasia. Telangiectasias can occur on mucosal surfaces and visceral organs. AVMs can occur in mucosal surfaces and visceral organs. Most of the time, telangiectasias are on mucocutaneous surfaces, and the bigger lesions are in organs. All right, so diagnosis of HHT actually does not require genetic testing. It requires a few minutes chatting with your patient and looking at their face and their mouth and their hands. They don't even have to disrobe, right? So spontaneous or recurrent epistaxis is usually the chief complaint or something that is easily elicited on a history. Mucocutaneous telangiectasias, you can see, these do not have to be 10 or 20 of them. It can be 3, it can be 4. Younger patients tend to have fewer, older patients tend to have more. And you just take a look at the tips of the fingers, look at their face, look at their ears, look in their mouth, their lips. If you see a few of these almost cherry red appearing, usually flat, but sometimes raised, red spots that can be 1 millimeter, 2 millimeters, 3 millimeters. They can be bigger. Those are classic telangiectasias of HHT in classic locations. And they are typically circle or sometimes moth-eaten appearing oval lesions. Okay. These are not spidery looking things like a patient with chronic liver disease who has telangiectasias will have. Visceral AVMs, certainly you can't tell by just chatting with the patient, although you may have a history that is suspicious for visceral AVMs, like an older patient that has high output heart failure, for example, or a family history of early liver disease or of strokes for no good reason from lung AVMs, things like this. And of course, family history of nosebleeds. My mom had nosebleeds and my sister has nosebleeds, and right, that an adult with recurrent nosebleeds, particularly an adult with a family history of recurrent nosebleeds, has HHT until proven otherwise. Could they have von Willebrand disease? They could. It's easy to rule out von Willebrand disease, and it's much more, the HHT in general is much more morbid, right? So you don't want to miss HHT. A lot of these patients have type O blood, and they have slightly low von Willebrand factor levels, and they have assigned a diagnosis of mild von Willebrand disease or low von Willebrand factor as a cause of their epistaxis, and that ends up being wrong, and it's really HHT. So if you have 3 or 4 criteria, you have a diagnosis of HHT that is definite. You actually don't need anything else to make the diagnosis. We recommend, and the guidelines recommend, confirming with genetic testing, and it's important because there are different manifestations of different types of HHT, particularly if you have SMAD4 mutant HHT, which causes juvenile polyposis HHT syndrome, in which people have all the manifestations of HHT, but also have hematomatous polyps throughout their intestines and a very high risk of intestinal cancer and need to be monitored for that and managed for that as well as their HHT. But you don't need genetic testing to actually assign a diagnosis that is concrete and confirmed. Okay. The average delay in diagnosis, at least in the United States, is 21 years, which we just saw on the Chorus registry initial publication, which I know was shared with everybody before the talk. So these are some of my patients. These are really obvious telangiectasias and people that have a lot of them, right? But more commonly, you find somebody, they might have 3 or 4 or 5. They don't have a ton. These are older patients that tend to have more. And again, similar here, these are plentiful and they're larger than typical, but just, again, very obvious sort of lesions. They don't need to be this obvious. In the intestines, as I mentioned, they tend to cause chronic gastrointestinal bleeding that affects about a third of patients with HHT and drives a lot of iron deficiency and iron deficiency anemia. And the nose, an astute otolaryngology doctor will look and see these lesions and say, I think you might have HHT. I'm going to send you to hematology to diagnose your HHT. The pulmonary arteriovenous malformations affect half of patients. These are portals, right, that bypass the physiologic filter of the lungs and allow for paradoxical embolism, just like a PFO can cause a stroke in patients. This can cause or lead to a stroke, right? Paradoxical embolism of clot can allow for bacteria to cross from arterial circulation, excuse me, from venous circulation, which bacteria sees venous circulation every time someone brushes their teeth, and nasal bacteria can enter the venous circulation through nasal telangiectasias, right? And they can cross into the arterial circulation across a pulmonary AVM and lodge in the brain and cause a brain abscess, or lodge in a joint capsule, cause a joint capsule abscess, all sorts of issues. Pulmonary AVMs also lead to high rates of migraines. So if you have a patient with HHT that has problems with migraines, they may have an undiagnosed pulmonary AVM. And of course, these lesions can hemorrhage. And this is something that is probably the most feared complication of pulmonary AVMs is hemorrhage. Thankfully, it's only about 2% of patients with HHT. That's, not huge, but also not trivial. And a pregnant woman with HHT has a 1% risk of pulmonary hemorrhage for each pregnancy. So from a pulmonary AVM, because pregnancy hormones can cause any AVMs, but including AVMs in the lungs, to grow and become more unstable. Hepatic AVMs affect about 3/4 of patients with HHT. A lot of these patients aren't even screened. Thankfully, most of these are clinically silent, and the patient will die with them, not of them. But about 10 to 15% of these patients will have serious clinical complications of their hepatic AVMs, like high output heart failure, like liver disease caused by ischemic cholangiopathy. This can lead to full-blown cirrhosis. It can be very bad. And when people do develop complications of the liver AVMs, they tend to be the thing that takes their life. Brain AVMs affect 10 to 20% of patients with HHT, cause intracranial hemorrhage in at least 3% of patients with HHT. Those are the patients that survived the hemorrhage and made it to the point where they enrolled under the registry where we got that 3% number. So it's probably a higher number in reality. Brain MRIs indicated at the time of diagnosis of HHT in order to check for these, rule them out, and see if they are potentially unsafe and require intervention. I mentioned the rates of pulmonary and brain AVM hemorrhage already, but I do think that it is instructive to remind ourselves that thanks to fantastic advances in hemophilia, right, a disease that in the 90s definitely had the highest rates of intracranial hemorrhage of any inherited bleeding disorder, we now have rates of modern rates, at least in the American registry, Athens registry, of intracranial hemorrhage in patients on non-factor prophylaxis of about 0.3, 0.4%, and patients on factor prophylaxis of about 1.5%. In patients with HHT, it's closer to 3%, right? And none of our treatments, including the treatments I'm going to mention to you, have any impact on this brain hemorrhage risk. And 2/3 of the hemorrhages happen in people under the age of 25, right? And the average age of diagnosis of HHT is age 37 in the United States, right? So, and it's probably like this. We know that diagnostic delay is a problem all over the world with this disease, because this is a disease that gets worse as people get older and often presents with no symptoms at all in early childhood. And so this is something that we have to keep in mind, and almost certainly we're missing a bunch of patients that have brain hemorrhages. And it's quite common for families with HHT, if you take a strong enough family history, for young people to have died of unclear causes or of brain aneurysms or whatever, right? These could have been brain AVMs. Other solid organ complications. 1 in 6 patients with HHT will have venous or arterial thromboembolism. The arterial thromboembolism primary strokes driven by brain AVM, or excuse me, by pulmonary AVMs. These patients have an increased risk of VTE over the general population. They can have aneurysms of any artery. That can be aortic, it can be splanchnic, it can be brain. This is almost certainly an underestimate. This number comes from people that just had them incidentally discovered or found on other imaging, obtained for other reasons. Pulmonary hypertension and heart failure affect 1 in 10 patients. in combination. So between those two, it's 1 in 10 patients with serious cardiopulmonary complications, and that means there's some overlap there. Liver AVMs can lead to high output heart failure, and liver AVMs can also lead to secondary pulmonary hypertension. There's also primary arterial pulmonary hypertension that can occur in these patients just as a result of their genetic lesion. I mentioned migraines, epilepsy, and the deep-seated tissue infections as well. All right, so not to belabor these points, but this is a highly morbid disease, right, with a huge amount of preventable morbidity and mortality, and that is our job to be sure that we are adequately treating bleeding, adequately treating anemia, and preventing serious AVM complications. All right, so how do we treat iron deficiency in HHT? Well, these are iron products we have available in the US. I believe in South Africa, if I'm not mistaken, you have all of these except for ferromoxitol and ferric gluconate. So really, the key here is avoid ferric carboxymaltose, right? Ferric carboxymaltose is convenient. It is quick. The patient only is in the chair for 20 minutes, but they have these patients with a single infusion have about a 50 to 75% risk of developing hypophosphatemia. All right, and I'll tell you more about why that hypophosphatemia matters and why it happens. But in patients who have chronic bleeding problems, right, and you're giving them FCM over and over and over again, right, you can slowly demineralize their skeleton and cause insufficiency fractures, which there was a recent Blood paper detailing this and many of the reasons why. Both the carbohydrate shell of both the carboxymaltose moiety itself causes the body to not be able to break down a hormone called intact FGF23, which I'll talk more about, and it lodges itself into bone, okay, causing direct problems in the bone. Any other product is fine, okay? It's obviously more convenient to give more iron in a single infusion so that patients are not, sitting in the constantly coming to the infusion suite to get 200 milligrams of iron sucrose each time, right? Low molecular iron dextran is cheap. I know it's available in South Africa. It's great. There's no problem with it. You can give it over 1 hour safely. If you have access to ferric diisomaltose, which is newer and more expensive, but I know is available in South Africa, that is really an ideal agent because it is a short duration infusion and extremely low risk of hypophosphatemia. All right, so a few cases here just to guide our discussion of iron. 35-year-old woman with HHT complicated by epistaxis and heavy menstrual bleeding presents with fatigue and alopecia. She has HHT as her main manifestations. HHT main manifestations being recurrent epistaxis. She has had a pulmonary AVM. She has heavy menstrual bleeding. She's tried PO iron, but it's not doing the job. She's anxious about getting IV iron because her sister, who also has HHT, had an infusion reaction to IV iron, and she witnessed it. She asked to receive the formulation of IV iron with the lowest risk of an infusion reaction. All right, so what is that? How do we manage this patient? So the thing that tends to drive complement-mediated non-anaphylactic infusion reactions in IV iron is labile-free iron. And so labile-free iron tends to be higher in our older formulations than our newer formulations. So ideally, we would give this patient, in the US, we could give ferromoxitol or iron isomaltoside, which is ferric diisomaltose, same thing. And if not, we could give low molecular iron dextran. If insurance forces us, we would give iron sucrose, but again, that's more infusions, and that is more opportunities to have an infusion reaction because it's more infusions and it's more labile-free iron with each infusion. So remember, right, most, probably 99% of IV iron infusion reactions are complement activation related pseudoallergy or CARPA. These patients do not have wheezing or stridor or hypotension. They might have isolated urticaria, not generalized urticaria. If they do not have any clear IgE-mediated hypersensitivity issues, they are having CARPA. And the iron infusion can be stopped. They can be given steroid and H2 blocker, and the iron infusion restarted at a lower rate. Most of these patients can also have back pain, and they even can have chest tightness, right? This is all related to complement activation as pseudoallergy. If someone has true hypotension or wheezing or stridor, right, that is your medical emergency anaphylaxis and appropriate to give, the epinephrine and the H1 blocker and the H2 blocker and the steroid. But a lot of patients with CARPA end up getting epinephrine and an H1 blocker, and that just blows the whole situation out of proportion and makes everything worse. In a systematic review and meta-analysis of infusion reactions, there was no increase in risk of serious adverse reactions in patients receiving IV iron compared to the control. The control, this is 103 clinical trials, over 10,000 patients. The control could be oral iron, it could be no iron, it could be placebo, it could be in a small amount of patients, thankfully, only a small amount of patients, intramuscular iron. But there was really the concern about anaphylaxis here is really driven primarily by historical concerns about high molecular weight iron dextran, which is no longer available. Just to look at a study that was powered to assess risk of hypersensitivity reactions, this is really low with every formulation. There really is no formulation that, including low molecular weight dextran, that really causes a higher risk of true hypersensitivity reactions. You can get more complement-mediated reactions with iron sucrose and iron dextran over ferric carboxymaltose and ferric diisomaltose, but not anaphylactic reactions. Okay, not to belabor the point. And in meta-analysis, if you look at all overall safety data, ferric diisomaltose is better than ferric carboxymaltose. Again, not a surprise because there's so much hypophosphatemia with ferric carboxymaltose. Ferric diisomaltose better than iron sucrose better than ferric carboxymaltose. Okay. Case 2, 45-year-old man with HHT complicated by epistaxis, chronic GI bleeding, presents with weakness and growing pain, presents to established care, has had recurrent epistaxis since early childhood, worsening over time. First diagnosed with chronic GI bleeding 3 years ago and presented with a hemoglobin of 6.2, was started on ferric carboxymaltose 1,000 milligrams approximately Q3 months by his prior hematologist, presents today with bilateral growing pain, waddling gait. Hemoglobin is 12, ferritin is 88, iron saturation 11%. This is not terrible, not ideal, but not terrible. How to manage this patient? Why is he waddling? So on a chest x-ray, it's normal. There's nothing wrong. What now? Well, if you said MRI, you were right. So this recurrent ferric carboxymaltose has caused hypophosphatemic osteomalacia, where his femoral necks bilaterally have been demineralized. The bone has been demineralized, and we see those black voids going through the femoral necks bilaterally. Those are insufficiency fractures, also called pseudofractures or looser zones. And this is causing bilateral hip instability and severe pain. This guy's only 45 years old. So why does this happen? So I already mentioned ferric carboxymaltose, this carboxymaltose moiety. It prevents normal physiologic breakdown of a hormone called FGF23. And you have increase in the level of intact FGF23, which is a very, very potent hyperphosphaturic hormone. It also reduces biologic activation of vitamin D in the gut and increases parathyroid hormone. So what do you end up getting? You get hypophosphatemia. That can be mild, it can be moderate, it can be severe, but it tends to be long lasting, and it is completely resistant to phosphate repletion. Right? So you can give as much oral phosphate or IV phosphate as you want. The main lesion here is in the kidneys. Patient will pee it out within a few hours. This lesion tends to last for weeks. It may last for months. In the United States, this is recognized as a rapidly growing iatrogenic and completely preventable problem through reports to the US FDA. This has certainly been recognized in many other countries as well. Most of the patients in these reports were disabled, hospitalized, died, or had life-threatening complications of this a totally iatrogenic, completely preventable problem with ferric carboxymaltose causing hypophosphatemia and its complications. And, these are just the cases that are reported, right? There's so many more that are not ever reported or not even recognized. So just as a reminder, we're not nephrologists, but let's play amateur nephrologist for a moment, right? If for hypophosphatemia, if you're less than 2.5 milligram per deciliter, you are at the risk for long-term complications, right? These patients might have some mild musculoskeletal short-term symptoms like muscle aches and pains. We just treated their iron deficiency, right? So there's a lot of overlap with hypophosphatemia symptoms and iron deficiency symptoms. Most of them feel better because treating iron deficiency makes you feel so much better. It masks the hypophosphatemia, right? So you can have a patient that has a phosphate of 1.9 or 1.8, mild hypophosphatemia, but if they constantly have that for weeks to months and you're constantly re-pinging it by giving more ferric carboxymaltose, you are slowly demineralizing their skeleton without them ever developing severe hypophosphatemia. So that's why the risk here is for long-term complications. But in the 10% of patients who get FCM who develop a severe hypophosphatemia less than 1 milligram per deciliter, they're at risk for serious acute complications like respiratory failure, hemolysis, musculoskeletal breakdown, rhabdomyolysis, cardiac dysfunction. So I'm going to show you some clinical trials that really make this point. Ferromoxetol versus ferrocarboxymaltose. Both groups, patients had normal phosphate at baseline, 50% developed hypophosphatemia in the FCM arm versus almost nobody in the ferromoxetol arm. At 5 weeks, a third of the FCM patients were still hypophosphatemic, and about 10% of the FCM patients developed more severe hypophosphatemia. Again, this is due to spikes in intact FGF23. When looked on analysis rate, the odds ratio for why this happened was 250 for getting FCM. Nothing else really mattered. In another study that compared ferric diisomaltose with ferric carboxymaltose, 75% of patients developed hypophosphatemia in the ferric carboxymaltose arm versus 8% in the ferric diisomaltose arm. 0% in the ferric diisomaltose arm developed severe hypophosphatemia versus 11% in the FCM arm. And again, this lingers for a long time, generally up to 3 months. Looking at the reason, right, intact FGF23 went up, phosphate, serum phosphate went down, urinary excretion of phosphate skyrockets. In another study called Falsifair IBD, which again was, this was a double-blind RCT of FDI versus FCM, and the primary outcome was incident hypophosphatemia. We see again rates of hypophosphatemia of over 50% in patients receiving FCM versus less than 10% with FDI, and we see it lingering over time in a significant percentage of the patients. Importantly, right, you get the same amount of iron, you restore the anemia, you treat the anemia to the same degree, but you get only half of the facet fatigue improvement. Again, in this double-blind clinical trial, right, people did not know what they were getting, but if you gave FCM, their facet fatigue improvement was only half what it was if you gave FDI because you were causing hypophosphatemia. And the improvements here, or lack thereof of improvements, completely correlated with how much the patient's phosphate went down. What other things can this cause? In addition to fractures and osteomalacia, it can cause kidney stones, right? Because you're causing a lot of phosphate to pass through the kidneys. And actually, when you treat with phosphate and calcitriol, which some people try to treat with those things, again, it's not really, it doesn't really do much. You just increase the risk of kidney stones even further. And a single dose of FCM increased fracture risk in this retrospective study of almost 5-fold compared with FDI. So this patient got nails in their femoral necks bilaterally. His intact FGF23 tested from an archived sample was extremely high, switched to another IV iron product that causes his bones to remineralize and this to not occur again. Again, there's now hundreds of case reports of this complication. And I have this slide in here just to remind us that this can happen with that serious complications happen with just a single dose of FCM, right? So if you give, this was a 20-year-old woman who just had heavy menstrual bleeding, who got a single course of FCM and ended up in the hospital with severe hypophosphatemia and respiratory failure and was intubated, right? And given Herculean doses of IV and PO phosphate over 2 weeks before her phosphate finally normalized. So there are some myths regarding FCM treatment emergent hypophosphatemia. Some people think it's not clinically relevant. I think we have debunked that. Right, for individuals who give FCM a lot, if you don't check the phosphate level, you're not going to see it. And there's the problems overlap with other things, and the bony issues are chronic and long-term, and these patients can get referred to rheumatology, who can make diagnoses of seronegative RA and all these other things as the cause of their chronic pain. If there are pediatricians in the audience, myth number three is that this is not a problem in kids. It most certainly is a problem in kids. The rate seems to be lower, but I don't know about you. I don't think this is good for a growing skeleton. And myth number four is it doesn't happen in pregnant women, and it again most certainly does. And this is not well recognized. The rates are around 15 to 45%, but this again probably not fantastic for a fetus either. Can this be treated? Not really. It's a preventable thing. There is an antibody called burosumab, which is an antibody directed against intact FGF23 that's used to treat congenital X-linked hypophosphatemic rickets and also used off-label to treat the paraneoplastic syndrome tumor-induced osteomalacia, in which a tumor is producing intact FGF23, but it's very expensive. All right, let's finish up the talk by talking about how to treat bleeding in HHT. So I already mentioned, right, the iron piece. If someone is presenting with acute unstable bleeding, you do what you got to do. You give that patient, pack their nose in the ER. If it's nasal bleeding, IV antifibrinolytics can be used for both nasal and GI bleeding. Generally speaking, these patients will get procedures, particularly if they present with a hemoglobin of 3 or 4 and severe chronic GI bleeding. You do what you need to do. You do those procedures. That's totally fine in the acute setting. We have really moved away from recurrent procedures in the chronic stable setting, which is the vast majority of the time, because again, this is an angiogenic problem. And the more tissue injury you cause, we have both clinical and very good basic science data to show this, the more telangiectasias and AVMs you provoke to form, right? And patients have been telling us this for years, oh yeah, the cautery helped for 3 months and then my bleeding came back worse than before, right? So for long-term treatment, right, the paradigm has really shifted to systemic therapy, right? And as hematologists, right, these are our drugs. Antifibrinolytics for patients with more moderate severe bleeding as an initial first step, and systemic anti-angiogenics or clinical trials of novel therapies in those patients that have more moderate to severe bleeding at baseline. So just a brief word about local ablative therapies and surgical management. Again, we can use these in the acute setting, primarily the local ablative therapies in the nose and in the gut. There are some more significant surgical procedures that are of more historical interest, nasal septodermoplasties, which are skin grafts to the nose, which most of the time ultimately slough off and require a very experienced ENT for them to be really even an option. They can also become colonized with bacteria and have a significant malodor, which is problematic because they're in the person's nose, and they can become infected and so on and so forth. But some patients, a minority of patients that have had septodermoplasties have had good responses to them. And then nasal closures or Young's procedures, which are exactly what they sound. You're closing up the nares. This can reduce bleeding out of anteriorly, but the patient will still bleed down the back of their throat. All right, so again, just to remind us of the pathophysiology here, we have excessive proangiogenic signaling, so we can reduce that with anti-angiogenic therapies like bevacizumab and pazopanib. We also use immunomodulatory IMiD drugs, which do work on blood vessel structure, but are primarily working on improving the structural integrity of blood vessels by increasing pericyte coverage of the abnormal blood vessels, which I don't have as part of this cartoon. And then AKT inhibitors, which I'll mention briefly as a newer modality. So in patients that have chronic severe HHT-associated bleeding, anti-angiogenic therapy really can be life-changing. This is one of the very first patients that we treated who was a fixture in our blood bank. We treated her with bevacizumab for the first time well over a decade ago. And she was liberated from transfusions and her hemoglobin was normalized and everything was amazing for about 5 years. And then she started losing her response to the bevacizumab and eventually was back on blood transfusions. So, treating this disease in many ways is like treating a cancer in slow motion, where instead of the patient progressing after months, they tend to progress after years. And, about, I would say, half of patients will progress past bevacizumab or pomalidomide or pazopanib after about 3 to 5 years on average of being on them. But, right, you can go to another therapy, right? And that other therapy will often work. But this is really life-changing and can be life-saving in patients with very severe bleeding. Patients also can have involution of their skin and mucous membrane telangiectasias, which everybody is very satisfied with. Just to give you some retrospective data, large observational multi-center study of bevacizumab and HHT called Inhibit Bleed. We see significant improvements in hemoglobin and epistaxis severity score, which is a 10-point validated bleeding score in HHT. That's very easy to administer. You can go to hhtess.com, or if you forget that, you can just Google nosebleed score in HHT and it will come up as the first search result. And it's a 6-question questionnaire where 0 is no bleeding and 10 is the worst bleeding. Very simple. We can see significant improvements in the epistaxis severity score. We see significant improvements in red cell transfusions in those who required them at baseline, as well as IV iron infusions in those who required them at baseline. What about toxicity? So this is a retrospective study, so toxicity is not perfectly captured in retrospective studies, but we saw hypertension, we saw fatigue, proteinuria. In general, right, for patients that have moderate severe bleeding, the risk is worth the benefit of administering, the benefit outweighs the risk of administering systemic bevacizumab. One thing that comes up, a question that comes up a lot is what about thrombosis risk, which we know anti-angiogenic agents in cancer have a thrombosis risk. This is a risk that is theoretical. It's something that you should counsel your patients about. I certainly counsel my patients about, and I get informed consent before using anti-neoplastic agents in patients with HHT. But nevertheless, we have not really seen a clear signal for increased thrombosis risk in patients with HHT, at least in retrospective studies of bevacizumab and in prospective studies of pomalidomide. So what about immunomodulatory IMiD drugs, right? So we have thalidomide, which is older and cheaper, but causes neuropathy. And we have newer drugs, particularly pomalidomide, which don't have that neuropathy concern like thalidomide does. These drugs, they have anti-angiogenic properties. They also upregulate endothelial production of platelet-derived growth factor beta, or PDGF beta, that causes increase in pericyte coverage and reduce the leakiness of the blood vessels. And that's believed to be the main mechanism of action. It is not believed to have anything to do with cereblon and cereblon mediated effects like in multiple myeloma. All right, the cereblon mediated effects are probably off target and cause, the neutropenia and some of the teratogenicity issues. These immunomodulatory IMiD drugs treat HHT through a non-cereblide binding moiety. It's clear that these work. The randomized trial was done in pomalidomide, not in thalidomide, which has less toxicity. And this was done in the PATH HHT study, which was done in the United States. And both myself and Dr. Pishko had the pleasure of serving as investigators in this study. Patients were randomized to receive pomalidomide or placebo. The dosing was 4 milligrams daily, which is actually higher dosing intensity, right, than a typical patient with myeloma who has 3 weeks on, 1 week off. And patients with HHT, we don't have the week off. But in patients who have side effects, 4 milligram daily, you can dose reduce to 3 and sometimes 2 and still maintain the effect. So we published in the New England Journal of Medicine a couple of years ago the results of this study, which as a randomized placebo-controlled trial, right, there were significant, both clinically significant and statistically significant improvements in epistaxis severity score with the pomalidomide over placebo. You can see there is that placebo effect with ESS. These patients were very excited to be on a clinical trial to treat their disease, many of whom had never thought that they would come for them. But the improvement there is time limited and eventually goes back to normal. Same thing is true with HHT-specific health-related quality of life and improvement in the pomalidomide arm over the placebo arm. In terms of toxicity, right, we see the most common side effects with single-agent pomalidomide in patients with HHT are constipation, really constipation, neutropenia, and rash, like the fatigue here. These patients were pretty much all iron deficient. So the difference here between the pomalidomide and placebo arms is really in constipation, neutropenia, and rash. The rash tends to be a very short-lived salmon-colored rash that usually has no significant symptoms, but in about 3 to 4% of patients, they can have a hypersensitivity rash. That means they cannot stay on the pomalidomide. Constipation usually gets better with time. Neutropenia is really the main toxicity that causes us to dose reduce pomalidomide, and that's something to keep an eye on. In terms of managing visceral AVMs, right? So I have a slide on this, right? This is primarily done by our colleagues in interventional radiology and in neurosurgery and neuro-IR for pulmonary and brain AVMs. But important to note that pulmonary AVMs really should always be intervened on if they have a feeding vessel of at least 3 millimeters in diameter. And this is something, right, just if the patient has a pulmonary AVM on their CTA of their chest, just refer them to interventional radiology to evaluate, and if they can be intervened upon, they should be intervened upon with embolization and coiling. Brain AVMs is a case-by-case basis, right? So brain AVMs can be in very sensitive locations. They can, the procedures here are higher risk than pulmonary AVMs. There is embolotherapy as an option, also radiation therapy and microsurgery, right? Not something that none of these things you do without some significant thought and evaluation by neuro interventional specialists. Some brain AVMs are low risk, some brain AVMs are higher risk. The higher risk lesions really should be intervened upon. The lower risk lesions can be monitored. There are also other HHT associated brain vascular abnormalities like telangiectasias, like congenital venous anomalies that can be lower risk that often do not require intervention. Liver AVMs are really a challenging problem clinically. So you cannot embolize a hepatic AVM. It's associated with a very high unacceptable risk of mortality. Liver transplant is definitive. I have definitive in quotes here because liver transplants, the patient can and often does have recurrence of AVMs in the transplanted liver. But this is life-saving in patients that have end-stage liver problems from their AVMs or serious cardiopulmonary disease from their liver AVMs. But obviously is not the easiest thing to get, and you're trading one disease for another with immunosuppression. There is an emerging role for anti-angiogenic therapy. For patients that have diffuse microliver AVMs, bevacizumab can be helpful. There's case reports showing that, and a prospective non-randomized trial that monitored with echocardiogram, which is not really the best way to monitor high cardiac output. It's really best to monitor that with catheterization, right heart catheterization. But nevertheless, this is a consideration for patients and can sometimes be helpful if patients have early stage biliary ischemia. But we're really hoping that a lot of the emerging therapeutics that are being developed specifically for HHT, as opposed to drugs we have repurposed from cancer, are more effective in this regard. Right, so I had pazopanib on the picture. Pazopanib has been less well studied than bevacizumab in HHT. It does seem to have more of a toxicity burden, but can also be effective. Okay, this is a retrospective and no doubt biased because it's retrospective. In real life, it's not quite this good, but you certainly can rescue patients that have bevacizumab refractory disease, some patients with pazopanib, and this is an oral option that can be used. All right, so let's talk about, in the last few minutes, AKT inhibition in HHT, and then take your questions. So recently we had the pleasure of publishing the initial study of AKT inhibition in HHT of a drug called engacertib in the proof of concept randomized controlled trial. And in this study, and again, the resolution on these figures is a bit ruined by the wide error bars, but you can see that patients that were randomized to higher dose engosertib, this was a randomized trial of patients receiving engosertib 30 milligram once daily, 40 milligram once daily, or placebo once daily. Those patients randomized to higher dose engosertib had clear improvements in their epistaxis parameters. And in fact, the randomized period of this study was only 12 weeks, which was really not long enough to show much of a difference with vascular remodeling agents. When you look in the open label extension, that's where the drug really began to shine, and patients having 50, 60, 70% reduction in epistaxis frequency and severity. And this is also true in terms of improvements in epistaxis severity score. So engosertib was well tolerated as an oral agent. Certainly it has a better toxicity profile than any of our off-label cancer drugs, and the phase 3 study is coming soon. The main toxicity of engosertib is a rash that occurs in about 40% of patients who get it, and is a garden variety drug rash that is short-lived. Actually, not 40%, about 20 to 30% of patients will get this garden variety drug rash that is short-lived. This drug also causes regression of telangiectasias visibly, and in patient-reported outcomes on the study, there was improvements in those patients that were dose-dependent on engosertib dose compared with placebo. The phase 3 heroic study is opening this year, actually. This is the pivotal phase 3 study of engosertib and HHT. So with that, I'm happy to take your questions. And I know Dr. Pishko will lead the Q&A.
Awesome. Thank you so much for an amazing talk on HHT. You covered a lot of ground in 1 hour, and I think
Yes.
we have about 30 minutes for questions. And so if anyone wants to drop your questions in the chat, you also can unmute. I'm going to start with some of the questions that we've already gotten in the chat. One was about that point you made regarding the goal ferritin. I think everybody resonated with them that indeed one cannot give too much iron in HHT. They were actually wondering about the ferritin level of 50 because they have actually heard that you could continue IV iron in HHT patients with chronic bleeding if the ferritin is less than 500. What is kind of your approach to that?
Oh yeah. So this is a really good question, a really good point. And my slide there was a bit of an oversimplification. So absolutely, you can continue IV iron in a patient with HHT if the ferritin is less than 500, right? So HHT, we know, causes inflammation, and that can cause ferritin to be elevated at baseline. So if someone has ferritin above 50 or above 100 or above 200, but has a low transferrin saturation, that person is iron deficient, and I would appropriately continue IV iron in that patient. The thresholds given, most of the younger patients with HHT tend to not have chronic inflammation, and that 50 threshold is really a very conservative threshold, right? A lot of folks will use a threshold of 100 in patients with HHT, but my point being, just don't let people drop really low.
Yeah, I think that is a very good point, and that sometimes people scheduled iron works for them a lot better than trying to play catch
Totally,
up like you mentioned.
totally. Yep.
Shifting gears a little bit, our next question is actually about what kind of radiologic features of micro AVMs in the liver, and I think kind of another question related to that is like what screening is recommended, or what do you do for screening for liver AVMs?
Excellent question. So micro AVMs in the liver tend to be AVMs that are too small for the radiologist to bother to measure, right? So normally they will just say there are innumerable small vascular lesions, likely AVMs in the setting of HHT, or they will say, and this is in the setting of, for example, an MRI, right? So MRI of the liver is really where you're going to have the sensitivity to be able to pick up on very small AVMs. I'll cut into answering this first question to answer the second question, which is that screening for liver AVMs can be done with a Doppler ultrasound of the liver or with an MRI of the liver. Doppler ultrasound is obviously cheaper. Doppler ultrasound will be, good at picking up macro AVMs if they're there. It's not going to be nearly as sensitive for picking up on diffuse microAVMs, which is not it's not an uncommon presentation. Oftentimes, people who have liver involvement of their HHT tend to have microAVMs, whether we can see them or not, and they may or may not have one or more macroAVMs. But in general, you're going to want to get a MRI liver with and without gadolinium, um, and tell the radiologist that the patient has HHT and that you're worried about potential AVMs, including micro AVMs, and they'll give you the sense for whether or not those are there. If somebody has micro AVMs, you might say, okay, do I need to do anything about this? Or if they have macro AVMs, again, for most patients, the answer is no, you don't. If the patient has a high output cardiac state on an echo or on a catheterization, or they have high output heart failure, then yes, that's a circumstance where we start talking about, do we need to do something about this? Potentially, if they have high output heart failure, right, it's very reasonable to treat with bevacizumab to try to reduce the cardiac output by impacting those micro AVMs. Obviously, you also want to make sure they're not anemic, which can contribute to their cardiac output. If they have high output cardiac state without actually having failure, they're compensated, then it's a gray area. Some people will treat to try to prevent things from progressing. Some people will monitor. I think it's really a shared decision at that stage. If someone has macro AVMs, like they're 3 and 4 and 5 centimeters, I really don't expect any of our off-label drugs to do anything for that. And in my hands, they haven't really. That doesn't mean that they won't benefit at all if they have a lot of shunting caused by micro AVMs, or if they have ischemic cholangiopathy caused by micro AVMs. But it's a more complicated question. I think I probably made more questions than I answered there. But
It's a hard topic.
yeah, Dr. Malongu has his hand raised.
Yeah, let's go to the hands from the crowd here.
Thank you very much, Hani, and good to see you. And thanks for this excellent talk. I've got two questions. One is you mentioned right at the beginning of your presentation that the individuals have got a reduced life expectancy, and I'm comparing here to hemophilia. We've changed that reduction in hemophilia to almost normal. What is the trend in the life expectancy of these patients in 2026? Is it still reduced and being reduced further, or is it in any way changing?
That's a great question. So there are a number of studies that have been published. The best study that's been published on this was actually just recently published, and I believe it was from Sweden. And it showed that patients tend to have about a decade of life loss, close to a decade of life loss on average. Now, this is in the current situation where there's, most HHT experts really have no doubts that there's a lot of intracranial hemorrhages that we're probably missing in younger patients, right, who don't have a diagnosis. So in the current diagnosed patient population, it's about loss of a decade. In the grander population, right, including patients that are having intracranial hemorrhage and dying of it before they're diagnosed, or intrapulmonary hemorrhage and dying of it before they're diagnosed, right, could that increase the mortality gap? It certainly could. But unlike hemophilia and other inherited bleeding disorders, right, HHT tends to get worse over the lifespan in terms of its more chronic manifestations and the more severe mucosal bleeding that can threaten someone's life, and the more severe AVM manifestations that primarily in the liver and the lungs that can threaten life. But loss of life early on appears to be more driven by brain intracranial hemorrhage.
Thank you very much. In fact, I'm going to ask one more question before Vernon Low. My apologies, Vernon. I can see your hand is very high. Can I just ask, just your thoughts on the potential of the current novel therapies that we are using in hemophilia for the treatment of HHT? Particularly the newer ones, monoclonal antibody directed against protein S, etc.
Yeah, I love that question. Thank you for asking that question. So I wanted to make sure I didn't go over time, so I didn't include a lot of emerging therapies. I just mentioned engacertib because we have data on it, but there's actually a whole host of other emerging therapeutics that target angiogenesis and that target coagulation. And so, for example, ALN-6400 is a plasminogen small interfering RNA agent that knocks down plasminogen, and by knocking it down very consistently, right, and much better than giving tranexamic acid 3 times a day, right, we can reduce, we can have a significant long-term reduction in the fibrinolytic impacts on these patients' mucous membrane bleeding and potentially improve their bleeding. You mentioned protein S modulation, like with latarcibart or VGA039, and that is, I think, potentially promising in HHT as well. There is, you have to recognize, right, that patients with HHT do not have reduced thrombin generation like patients with VWD or hemophilia. At the same time, I would probably not want to use a drug like fitusiran in HHT, but I think protein S modulation with an antibody like latarcibart could be potentially very effective at reducing mucosal bleeding, as it has been in the early von Willebrand disease studies. So I view the modulators of coagulation as potentially very promising in HHT, and it's just a matter of doing the initial work to ensure that those patients don't have untoward increases in D-dimers and prothrombin fragments and such that would give us an indication that there might be some unacceptable thrombosis risk. But yes, I do think that there is definite potential there.
Great. And we'll go to Vernon, and then we'll go to the people in the chat.
Hi there. Thanks, Hanny. Great to see you again, and thank you for a wonderful talk. So glad to have you speak to our society as well. I've got just a few comments and two questions as well. Comment-wise, I like your answer about the monitoring, because obviously we've seen that many of our patients, we need to give them IV iron almost sometimes every 2 weeks. Yep. And after a dose of IV iron, your ferritin goes up to 600-700, independent of iron status for about 4 weeks, sometimes up to 6 weeks.
Totally.
It becomes a very difficult thing to monitor. So I like the fact that you said use the fasting transferrin saturation. So thanks for that. The second comment, and apologies if you mentioned this, I was interrupted halfway through. Maybe just to say something about risk in scuba divers or even just free divers with AVMs in the brain, and about Kasabach-Merritt syndrome, which we've also seen with very large liver AVMs causing some pancytopenias. And my question then, we have much easier access to lenalidomide, and it's also a fraction of the price. If you could just maybe share your experience with comparative efficacy. And then secondly, in the early days, tamoxifen was proposed in very small cohort studies, and I have used it with quite some degree of success in the past, but one of the patients developed a superior mesenteric artery thrombosis, which I still don't know whether that was now related to that or not, but nevertheless, it gave me a huge fright. So I'd love to hear your comments on any of those. Thanks.
Absolutely. No, thank you, Dr. Lowe, for those really great questions. So yes, I'll take them one at a time. So the question of tamoxifen is a great question. So selective estrogen response modulators, tamoxifen, bazodoxifene, have both been evaluated in HHT. The data is very mixed. The same thing is true for estrogen. There was actually even a randomized control trial of just straight up oral estrogen for both men and women with HHT. And that was a negative study. It is definitely true that estrogen can reduce bleeding in certain patients with HHT. We have shied away from it in modern day, primarily because, right, and tamoxifen has also the longer term endometrial cancer risk in women. We know that it has a real thromboembolic risk. Now, you might say, well, wait a minute, what about bevacizumab and pomalidomide? Don't those have real thromboembolic risks? Well, They definitely do in patients with cancer. It's really not clear whether or not they do in patients with HHT, or at least it remains an open question. And the therapeutic impact that you usually get with an anti-androgenic drug, which is more disease targeted, it, generally speaking, is quite a bit better than estrogen-based therapy. So the risk benefit is more in favor, if we're going to use a systemic therapy, of using an anti-androgenic drug. But it doesn't mean that it's altogether inappropriate, right? There are, for example, women with HHT who would be using estrogen-containing contraception sometimes will opt for that route, recognizing the thrombosis risk, because they're hitting two birds with one stone, so to speak. But it's not something that, in general, the guidelines currently recommend for routine use these days. I would prefer, using, for example, an antifibrinolytic in a patient with HHT to treat both epistaxis and heavy menstrual bleeding over an estrogen-containing contraceptive. In terms of scuba diving, that's a great question. So it's very, very important that patients with HHT, not particularly if they have lung or brain AVMs, not go scuba diving. If that's something that's very important to them, there can be a discussion about risks, but it's very critical that their AVMs be appropriately intervened upon before that happens, right? Before they would go scuba diving. And then I think, remind me what your third question was.
I was just asking about lenalidomide as
Lenalidomide.
compared to
Thank you. Yes. There is no reason to believe that lenalidomide is not efficacious like pomalidomide is, and like thalidomide is in HHT. There's actually a case report of a patient with severe GI bleeding in HHT who was successfully treated with lenalidomide. The issue with lenalidomide is there's a couple. Number one, it's just a lack of data. There's just not a lot of data in HHT. There is more data in non-HHT vascular anomalies, like you mentioned, the Kasabach-Merritt situation. There is more data in the pediatric literature for lenalidomide and other non-HHT vascular anomalies, and that we do extrapolate sometimes between HHT and non-HHT in terms of treatment of large AVMs. I will say that there is some work that's been done by my colleague Adam Sperling, who's now at Stanford, showing that pomalidomide at least appears to not have that same risk of secondary malignancies as lenalidomide does. He did a really nice study published in Blood a few years ago that showed that len seems to select for p53 deficient clones in the marrow, and pom appears to not. And so that also drives my preference to use pom in patients who are, who don't have a malignancy and who have potentially a lot of years of life ahead. I think the secondary malignancy risk with len is very, very low, but that data does make me feel a little bit more comfortable with using POM. But again, not wrong to use len for HHT, but just a lot less data.
Thanks so much.
I'll go to the chat, and Dr. Kennedy, feel free to unmute yourself if you can, but I'll start off your questions here. Is that one was a comment that she had made that was due to the lack of access to most systemic drugs, that they have used tamoxifen in HHT patients, and as you outlined, they also saw pretty variable success with that. One of the other questions that's been in the chat is, why is the response to systemic anti-angiogenics lost over time? Is this age-related, disease-related? Any hypothesis that you have there?
That's a $64,000 question, right? So nobody knows the answer to this. There are hypotheses. HHT is a progressive disease. And so, if you start bevacizumab on a 75-year-old with HHT, they may not respond, right? Is that somebody that could have responded 10 years ago before their disease had, quote unquote, progressed and gotten worse? Maybe. It's really not clear exactly why this happens. It does not appear to be due to immunologic phenomena like anti-drug antibodies to bevacizumab, for example. It is I don't have a great answer for you. It's something that needs to be investigated further. But one of the things that people will postulate is, if you use Bev or pazopanib, which are the two drugs that really are primarily used um, uh, uh, in that affect the VEGF pathway, there are definitely other uh, 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 angiogenic important angiogenic pathways that are not being affected. Like I showed the apelin receptor, for example, that's not being impacted by bevacizumab. There are other vascular endothelial growth factors like VEGF-C and VEGF-D that may also drive resistance. VEGF-A is the only VEGF that's blocked by bevacizumab. There is a pan-VEGF trap called Zaltrap or zivaflibercept that can sometimes be used in Bev refractory patients that can restore a response. Right, so it's an area of significant investigation right now.
I guess following up on that, perhaps an easier question is part two of Dr. Kennedy's question is how do you actually monitor for clinical response? Are you using the new composite hematologic endpoints? What kind of parameters are you using?
Yeah, that's a great question. So, in a patient who responds really fantastically well, it's one of these things where you don't really need statistics, right? You don't need something that's, a fancy tool necessarily. The patient will come off their red cell transfusions or they'll come off their iron infusions or both or what have you. But we do have good tools that can be used for patients that, have a more average type of response or in patient, just in general to monitor if you want to be sure that things aren't changing over time. Like, for example, the patient isn't slowly losing their response. So the epistaxis severity score is pretty easy to use in clinical practice, and it can be helpful at monitoring epistaxis. It's not perfect, but it's easy, and I think that's the most important thing for a tool that we use in clinic. Dr. Pishko mentioned composite hematologic measures, which are really, really now the standard in clinical trials of HHT. And you might say, what is a composite hematologic measure? So, right, a lot of these patients, particularly those patients who have more severe bleeding, very, very severe bleeding, they're getting iron and blood, right? And these measures combine different aspects of hematologic support together into a single measurement. So the hematologic support score, or HSS, combines red cell transfusion and intravenous iron. It's a very simple calculation. You just take the milligrams of intravenous iron infused and you divide by 250, and you add the number of red cell units transfused, and this is over a period of time, like over 3 months or 6 months, and you can look at the 3-month hematologic support requirements through the hematologic support score before starting an intervention like bevacizumab or any HHT intervention, and then look at it after, right, and compare those numbers and make sure that things have significantly improved or sufficiently improved. You can use what's called the hematologic impact score, which combines hematologic support score and hemoglobin. It's basically a hemoglobin adjusted hematologic support score. And both the hematologic support score and hematologic impact score read out in what are called red cell unit equivalents, because it just converts the IV iron based on the amount of iron that's in a unit of blood, about 250 milligrams, into a red cell unit equivalent. And 1 gram of hemoglobin is about 1 unit of red cells. So these are not exactly rocket science, but sort of very common sense measures. And you can, the publications describing them are available open access. You can take a look. If you have to prove to a pair that a patient has clearly improved, it's also helpful, to use objective markers like this. A patient can improve in their hemoglobin without improving in their IV iron requirements. That's still an improvement, right? If someone goes from a hemoglobin of 7 to 12, someone can improve in their IV iron requirements without improving their hemoglobin. That's still an improvement, right? So using composite measures like this can be helpful.
Great, thank you very much. Moving off of systemic therapies for a moment, back to iron supplementation. We have a question: is there a role for vitamin D supplementation in iatrogenic hypophosphatemia caused by FCM? Oops, I think we might be having a little bit of technical difficulties. We'll just give Dr. Al-Samkari a moment to see if he can get rejoined here. Oh, he is rejoining now. Apologies. Just one moment. We were almost to the end, but if you want to stay for the last 10 minutes, if he's able to rejoin, we can do that. Otherwise, we'll plan to conclude.
Sorry about that.
There he is. I don't know if you heard my question before the technical difficulties, but the question was, is there a role for vitamin D supplementation in iatrogenic hypophosphatemia?
That's a great question. It's not something that is expected to hurt, although some people do think that giving a lot of vitamin D can also increase the risk of kidney stones in those patients. Um, but it's also not really going to help. That's, I think, the main take home. So, you know, I hope that there's nobody in the audience that is required to use ferric carboxymaltose, right? Any other I mean, and again, for the vast majority of people who are just getting one dose of iron repletion, it's probably fine. Again, it's not something I would want, but it's probably okay. But for patients with HHT, right, it's definitely not okay. Actually, I think it's important to say there was the FDA has just appended a black box warning. They're appending in the process of appending a black box warning to ferric carboxymaltose in the United States for the hypophosphatemic osteomalacia and bony complications. This was a citizen petition that was driven by the Cure HHT Foundation to get this done, and it was successful. So, for people with HHT, it really should be viewed as essentially contraindicated if there's unless there's no other options. And those patients, I monitor phosphate and hope that things don't monitor DEXA scans and things like that. But it's a very challenging situation. But I would just avoid it rather than trying to treat it with vitamin D or phosphate.
Great. And maybe we have time for just one final question, I think is an important one. In patients with borderline symptoms, are there any comorbid conditions that kind of may exacerbate their presenting symptoms or like medications that you should avoid? And
Oh,
also, how
that's a
does
good
that
question.
help you choose therapies too, based on comorbid conditions?
That's a great question. I mean, obviously, there's a lot more to talk about. It's a big space, but patients with HHT can be exquisitely sensitive to antiplatelet medications. So about 50% of patients with HHT do okay. I should say just fine, but do okay on anticoagulation or antiplatelet therapy. But there's a lot, and it's impossible to tell who the person's going to be, who you put them on a baby aspirin and they go from having mild bleeding to just having really awful bleeding, and it's just like horrible for them. The same thing can be true with SSRIs and fish oil and turmeric and supplements and other medications that can have what we would normally think of as a trivial effect on platelet function in an average person. But that can, in certain patients with HHT, cause their epistaxis and or GI bleeding to really flare up. So it's something to consider. And I think running the medication list and making sure that there are no medications or supplements. And right, a lot of people take fish oil. A lot of people take turmeric for arthritis, right? And they don't realize that they're reducing their platelet function. And God only knows how much turmeric is in some of these supplements, right? It could be a lot, it could be a little, who knows, right? So, yeah, I think it's appropriate and reasonable to have that as part of your kind of bleeding history with these patients. Other conditions, patients with HHT can also have von Willebrand disease. I have a few of those patients. Patients with HHT can have, can be carriers for factor VII deficiency or whatever, right? It can be, there can be other things. So, not saying you need to order a comprehensive coagulation evaluation in every patient with HHT, but if something is just not seeming right, if the patient seems to have disease out of proportion for, bleeding out of proportion for what the rest of their disease is, or they're really young and have really awful disease or something like this, it's not unreasonable to make sure there isn't something else going on.
Awesome. Thank you again for a fantastic talk, and for to the audience for being so engaging. I think we all learned a lot. Thank you again for joining. There is going to be a feedback survey if you look in the chat from Cure HHT. Your input really helps us support future HHT education and resources. And thank you again for the presentation, and to our audience. It's been a pleasure.
Thank you so much for inviting us to speak.
Thanks so much.
Thank you so much. Have a good afternoon. Bye.
All right. Have a good one, everybody.